Dr. Jill Kimball, Dr. Debbie Rosenbaum, our Sharacetic in-house experts on the coronavirus. They've provided us great guidance in the past, and we have a number of subjects that they're going to tackle. So why don't we start off with number one, which is how does the virus spread? What do we know?
Sure. Well, first, thanks, Rabbi, for giving us the opportunity to do this again. And I should tell everybody, like Debbie and I are not epidemiologists and we're not infectious disease experts, but we do try to read a lot and we speak to very smart people at St. Paul's. So I feel like we can give some good, reliable information. And I think that one of the lessons is in this pandemic and in other things in science is really the source of the information. And so we rely on really evidence-based sources that are really good journals, and that's where we're getting the information from. But when we give things change, and so some of the stuff that we talked about at the beginning may have been updated, and things that we talk about tonight may be proven to be wrong. So we'll just give you our best evidence and best advice based on what we read and what we talk about. And the other thing I'll say is that there's a lot of material to cover, but what I think is really important, and some of the feedback that we got last time was that just to maybe go into make sure that I want to make sure everybody understands what we do, and if we don't cover everything this time, we can cover it next time. And with that, I would love it. I know it's totally optional, but I would love it if people turn on their cameras because it just makes it feel more interactive, but totally optional. I know it's late and whatever you're more comfortable with, but it makes me feel good when people have their cameras on. Okay, so why don't we start a little bit about how the virus spreads? And I think that's probably a really key question. And maybe one of the things I'll just start off by saying is that, obviously you can reduce your risk to getting COVID to zero by staying at home and not interacting with anybody, and you're not going to get COVID. It doesn't come in through the windows, it doesn't come in through the radio or internet. And so the question is, how much risk are you willing to take? Because obviously staying at home and not interacting with people is not the best quality of life. And so everybody has to make their own decisions, what risk they're comfortable with. And obviously at the other extreme would be, a lot of people that got into trouble would be those in a one-bedroom apartment that are having a party with 40 people with the windows closed and with the music on so that they're singing. That would be a very high risk atmosphere. So hopefully most people are near the first part, but we'll talk about some things that can help you reduce your risk, and then people can make their own decisions. But in terms of how the virus spreads, so the evidence is becoming pretty clear that the real problem with this virus is that you can spread it before you have symptoms. And so I want to make that clear because I think that this is really something that people really need to understand. You can spread it. In fact, the most infectious period is probably the day before you start having a cough and having a fever. And so then people say, well, how do you spread it? Well, when you're talking, you're actually producing quite a bit of virus particles that come out in small little water particles that you can't actually see. But one water particle contains more than enough virus to expose most people and to get sick. And so the question is, how much are you exposed to and for how long? And so there was actually a good paper that was shared last night, or a good article that was shared last night by the head of medicine actually at St. Paul's, that showed some interactive video about that. And basically it showed that if you're 6 people in a room and the windows are closed and everybody's wearing a mask and one person is infected, the risk is not zero. Actually, it's probably, I think 4 or 5 people would be exposed. Not everybody's going to get sick and not everybody's going to get very sick, but even if everybody's wearing masks, but the point is that they're in a room together for 4 hours with the windows closed. If they're in a room for only 1 hour in a small room, then the risk is far less. And if they're not wearing masks, of course, the risk would be far more. So I think actually that masks, like this is the kind that we use at St. Paul's, is a very effective way to reduce your risk, but it's not 100%. So even if you're wearing a mask and you're with somebody in a room that's also wearing a mask and one of the 2 people is infected, it's not zero risk, but it's much better. And then just to take one step further, and then I'll let Debbie fill in a bit more, but if you're outside and you're both wearing a mask, the risk is even lower because the air is changing around you. So the particles don't hover in the air and you can't breathe them in. And then if you're standing 6 feet apart and you're wearing a mask and you're outside, the risk is extremely low. So that's why I think even in the summer, we were quite comfortable with the kids playing outside because you're outside and you're moving around and the air circulates quite a bit. So the risk is very low. So the main risks are being indoors in a very dense place with some people that are sick. And even if they're talking or singing, and even if they're not coughing and don't have a fever, they are still able to spread the virus. So that I think is pretty definitive. And so we get nervous when we hear people say, well, obviously I don't have it because I'm not coughing and I don't have a fever. Well, you might tomorrow or the next day, but in the meantime, when you're around people that might be at risk, you can still be spreading it. So I think that that's a really important point to understand. And then, do you want to talk a little bit about the difference between aerosolized and droplet?
Yes.
Okay.
So when we spoke last, as Rabbi Rosenblatt said, this is a good way to see how science evolves over time. We were pretty confident, the medical field was pretty confident this was mostly droplet, spread by droplets, and maybe droplets falling on surfaces. So droplets in the air as well as droplets on surfaces is how we got the risk for getting the virus. And droplets are kind of like the way the flu spreads. It's a droplet like from a sneeze or a cough, and droplets go out into the air. But usually the droplets drop because gravity brings it down and it drops to the ground. The air current will bring it down and it'll drop to the ground. And we tend to not get infections from the ground. We get it while it's still in the air or if it lands on surfaces. And those particles are larger. They're like, I don't know, they're like 300, I wrote down micrometers, these particles. So they drop to the ground. And that's what we were thinking about the virus spread for a long time. But it's, as Gil said, it's now becoming more apparent that it's also aerosolized. And that's where everyone started hearing about indoors versus outdoors. Circulating the air with ventilation, air conditioners, windows open, how maybe talking, depending on how loud you talk, or singing increases the risk. So aerosolized particles are very small. So a droplet is like 100 micrometers or larger, and an aerosolized one is less than 100 micrometers. And that's what comes out with talking, with singing. So even just things that people do on a daily basis, so not the cough and the sneeze. And that's what Gil was saying, that risk with the aerosolized particles starts even before. And aerosolized particles, what?
The 100 micrometers, just for people who don't speak super science, that's about the width of a human hair.
Yeah, so they're very small.
You can't see it. And these particles, the aerosolized ones, stay in the air. So that's where the literature or the experts start recommending have ventilators, have something that moves the air so that the air current will move those aerosolized particles and drop them to the ground or spread them apart. And so Gil was saying, in a room, depending on how close people are together, how long people are together, the exposure with an aerosolized particle increases the longer you are in a room with someone, the closer you are in the room with someone. And depending on the volume, the way someone speaks, as well as the singing. And so one of the models that Gil was talking about that the head of medicine had sent out was that actually in a classroom, the students are less likely to be talking. It's more likely to be the teacher that's talking. And so if you're in a classroom with the same teacher who's speaking the entire time, the teacher's speaking and exposure to the classmates is to the students is likely higher risk than the students talking in the classroom, just because of the duration that the teacher's talking, and they tend to have to talk louder in the classroom. So masks by a teacher would be vital in a classroom just because of that exposure for a prolonged period of time. And then Gil started talking about the ways to mitigate this exposure if you're indoors for a prolonged period of time. So masks would be one, physical distancing is another, that ventilation to move the currents in the air. Doors open if you can, be outdoors over indoors would be preferable. And then the other thing is limit the amount of time you're exposing yourself to people, because time has also shown. Are you showing that?
Yes, I'm not me. That's Rabbi Rosenblatt.
Okay,
so that's
perfect.
what they sent us.
That's the article we were talking about, which shows great modeling.
And it's good data. It's from a scientist in Colorado. So we like that one.
Janaea, thank you for sending this link in. Mm-hmm. So people can.
And can I just make just one other comment? So in terms of the aerosolization, so we know that environments that are very dry and cold are much worse in terms of transmission. So it's easier to get it in that's why there were so many cases in abattoirs and in cold, dry areas, because the particles can hover. And obviously in moist and hot weather, it's harder for the particles to remain suspended. So they go down to the ground, and that reduces the risk of transmission. So that's why I think in Alberta and in Quebec also, there was much more transmission in cold areas. Now, maybe, so in terms of the next question was about just the evidence on mask wearing. So there's a couple of ways we could, there's a lot of papers that have been published, but I think the two main points to look at are, number one, if you look at the countries that have had excellent success in controlling the virus, in mitigation, as they say, are those countries where mask wearing has been mandated. Now, obviously in BC, Bonnie Henry has decided not to mandate it, but she made stronger language by saying she expects people to wear a mask. And I think that's really important, because if we look at countries like Taiwan, Hong Kong, Singapore, Japan, South Korea, where the virus has had pretty good control. There's been outbreaks from time to time, but they have worn masks. Whereas when the virus is rapidly spreading very early on, and now again, they're having the same problem in France, Spain, Germany, and to some extent Italy, at the early stage. So now masks are more common, but at the early part, there was no masks. And so that just means that there's more virus that's spread out and a higher chance of being in contact with the virus. And so that's why, there was a letter that some of you may have seen in the Vancouver Sun and even in the province, where there was 170 doctors from St. Paul's that signed it, because we really wanted the government to take a harder stance on masks, because the risk to wearing it is very low. And based on the evidence, we felt that it was very helpful. The studies really are there, what they do, which is not obviously, it's not human to human, but they have put basically small little masks on animals, and they're just looking for how much virus is spread during their normal breathing. And even when you're breathing and you're wearing a mask, some of it can still come out unless it's an N95, which still is not 100%. So if you ask me if you should wear a mask, yes, you should wear a mask when you go into any public place, unless you have a breathing problem and you can't breathe. And I think that people around you should be wearing masks too, that you're not, that you don't live with. And just to give you a personal example, at St. Paul's, when I'm there, I wear a mask the entire time, except when I'm in my office, I take it off. And if I'm in the elevator or in the staircase and I see people that aren't wearing masks, I tell them to put it on, because I think it's really important. And I think it's part of our social responsibility to try to protect others. And we know that it's helpful for others, but it's also helpful for ourselves.
That's so un-Canadian of you.
Yes. Perhaps it is, but that's my opinion. That's my opinion. And not everybody agrees with me, but 170 doctors at St. Paul's agree with me.
I think the key is to use all the tools you have in your toolbox to help prevention, and masks is one. This virus is with us. We talked in March about how long is it going to be with us, but still here. So we have to do what we know can lead to prevention. We know that every intervention on their own is not going to fully decrease the risk of transmission. So we should do everything that we can, and depending on the scenario that we're in. So masks, physical distancing, outside more than in, limit the time inside, air ventilation, good cough and sneezing hygiene, and then of course staying home if you're sick, right? That's a key thing too. So there's lots of different tools that we can do. So it's not just the mask, but definitely there is good evidence with the mask. The thing about the mask is, in medicine we like to have these randomized controlled trials, and it's not ethical to have a randomized controlled trial to see what will happen if you wear a mask. A group wears a mask and a group doesn't. So we're doing regression tests and also the animal studies to help guide if you're really seeking evidence.
Aren't there natural experiments based on countries or
Yes.
counties or provinces that have had masks? Do you
Yeah.
have any evidence from that suggests?
Yeah, there are some. There are. I don't have that handy. I don't have it handy, but definitely. There are evidence in certain places, and I think there is a natural study. Just one sec, let me see quickly. I think in Denmark, maybe.
So we had a whole bunch
Yeah.
of, we could send them out if
Yeah.
people want to read them, but
Oh yeah, for sure. So in outbreak settings like cruise ships, and it was naturally selected in cruise ships, people wearing masks versus those who weren't. It decreased the risk. In meat packing factories, there have been epidemiological studies. Those are two places where there were outbreak settings, but where masks reduced the risks. So it was just a retrospective review of it, and that's in the literature.
now let's just talk about something else that it's not in the top 3 questions, but I think it's really important just to go over. So when we get a vaccine, which is probably going to be in the spring or maybe in the summer, hopefully it's sooner. I think it's really important first to wait to see the data to make sure that it's safe and efficacious. But once that's good, then we of course recommend for people to get the vaccine. But even when we get a vaccine, it's not going to be 100% effective. And I heard a very interesting talk by Paul Offit, who we mentioned before. He was the one that invented the rotavirus vaccine for kids. And he basically said that in the best case scenario, it's going to be 75% effective. So what does that mean? It means if you get the 1 out of 4 people that get the vaccine that's exposed to the virus will get sick to the point where they need to go to the hospital or worse. And so, 3 out of 4 people will have very, very, very mild disease or nothing. And so even if we were in that scenario, we're probably still going to need to wear masks for a long, long time, because I don't think people are going to want to take a 1 in 4 chance of getting very sick, even if they had the vaccine. And the second part is that it looks more and more likely that the vaccine is not going to confer lifelong immunity like we have with measles. Like if you get the measles disease, your chance of getting measles again is 0. Like I don't think there's been any recorded cases. If you get the vaccine for measles, it's extremely, extremely low to get sick. But this is a different virus. This is a different type of infection. And so it looks like it's not going to be lifelong immunity, but I don't think people would be that disappointed if they had to get multiple vaccines per year, maybe 2 vaccines a year or more, who knows, if to prevent getting sick and being in the hospital and not being able to breathe comfortably. So I think that that's fine, but the question is the effectiveness. So it's not going to be 100%, and this latest studies show, and it's probably not going to be lifelong. So that means that we should get used more and more to wearing masks and social distancing for a long, long time. I know it doesn't sound great, but that's what it looks like.
Gil, I mean, I think that I assume that also means we're never going to shake people's hands again. And dinner guests, does that mean dinner guests will never happen again? And then also discuss, this is probably a good time to discuss the potential for to define and discuss the potential for this to become endemic.
Yeah, I think that's the word that they're using already, that it will be probably endemic.
So define that for everyone.
Yeah, endemic means that there'll always be some background virus floating around. But interestingly, there have been some countries, most notably New Zealand and Taiwan, that are pretty much eliminated it. Now they have the advantage of being an island, but I really appreciated their Prime Minister Jacinda Ardern's pathway, where she said, her quote was, "We're going to go hard and we're going to go early." And so she said, "We're going to stop the borders. Everybody stay home. We're going to stamp out this virus." And now the caseload is virtually 0. So of course, I like that pathway. It was up to me, I would say, let's close the border to Alberta. I'm not saying that we should, so please don't quote me on this. But of course, we could be more effective if we let the reason why the virus is coming up, and we see now in Fraser through the medical channels that it's worse, is because it's not so much that there's that much transmission in the grocery stores or in the pharmacies, because you're not in close contact with people, but people are obviously misbehaving and having parties, and one person comes there that doesn't know that they're infected and spreads it to 6 people, let's say, and then those even if 1 out of 6 people then does the same thing, then it spreads, and it can be exponential. And so I strongly support having social distancing and minimizing your exposure to others, especially if you're in a higher risk category. And even if you're in a low risk category, you don't want to get it because you can have a potential of being very sick. And I can tell you that in our ICU at St. Paul's, I probably shouldn't say the exact numbers of patients, but we have multiple patients in the intensive care unit, multiple patients that are on breathing machines, and multiple patients that are young. And so that's worrisome. And most patients, of course, do well at home, but you can't identify if you're going to be one of those that has a really rough time with it and needs airway support.
So Gil, just prognosticating a little bit, which I know you don't like to do, but so if the vaccine is less effective than is hoped, then what should we assume that the next 24 months look like this, or is our only hope then good interventions, some kind of drug which helps people who become infected or become dangerous to better survive?
A great question. Let's talk about drugs. But by the way, before we go further, I'm very positive. I'm very optimistic that things are going to be fine, but I think that we need to understand how to minimize our risk. That's why I'm being a little bit serious, but I am very optimistic. So I'm not nervous about our situation in BC. I'm going to work. Our kids are going to school. I'm also very pro for kids going to school because I think you have to accept some risk in life. And I think school definitely falls in that category. I think if we want to advance as a society, I think education is paramount. But if you ask me about other industries, I may not be as enthusiastic, but we don't have to go through those. But this paper here, so it just came out on Wednesday in the New England Journal of Medicine, which is one of the, I think, top sources. And in terms of medications that work, so let's go through them. And you've all heard of all these medications, but let's squash some of the myths and let's put some things to rest. So for sure, the hydroxychloroquine and chloroquine story is done. There has been several papers that have showed that it doesn't help and it may make it worse.
That's Plaquenil.
Plaquenil, yes. So those drugs, please do not buy them at the pharmacy. Let the people that have other diseases that need them get them. If you have it, I would dispose of it. It does not help with COVID and it may make it worse. But there was another drug, dexamethasone, which is very inexpensive. It's been around for a long time. And there was a study in Britain that showed that those patients that have moderate, very severe disease really benefit in terms of mortality. So that was a landmark study, and that has really changed the course of the disease. So that's great. And then there's Remdesavir, which is the drug from Gilead Scientific, which was originally developed for something else, but that has proven to be helpful, but only in those that are really, really sick. So if you have mild disease or moderate disease, it's not recommended. So those are the therapies. It's not really much, but dexamethasone had a huge impact.
And if you recall, when we spoke last, dexamethasone was actually on the list of drugs not to give. So they were avoiding it in Italy.
Because of SARS-1. The SARS-1, it made it worse. And so luckily somebody, because we know it's after the person gets infected, it's an inflammatory process where the lungs can get inflamed, which is kind of like a bad bruise, and the heart can get inflamed. And so the steroids have been proven to really be helpful. And let me just say one other thing about school. I think, I'm very impressed with VTT and with King David about mask wearing. And I think they're doing a great job. And I think that we should applaud the efforts that the schools are making to really make it as safe as possible and to continue education in the best possible way. So,
and you mentioned those schools because that's the schools that our kids go to. But
those are the ones I'm familiar with. Yeah. But I'm sure many schools are doing a fantastic job. But just those are the ones that we've been in close touch with. Thanks, Deb. Yes. Now, what, Rabbi, you asked another question that was, what was
you avoided the question, are we going to ever be able to have people at our house for dinner?
Yeah, I think, you know what, I don't know if it's going to be, if you ask me if we're going to have people over during the break, probably no. But if somebody comes to our backyard and sits outside, sure, because we know that the risk of transmission outside is very low, especially if you're 6 feet apart. So we have no problem having people come in our backyard and chat in the backyard, and we have one of those heater things, so we can sit down and relax. And so I think that being outside is good. And I've gone for walks with many times with people, and I'm not worried about that at all. But indoors in our classic party where there's talking and singing and hugging and kissing, no, I don't think that's going to be happening for a while.
Is a while like 2023?
I think years.
Years.
I mean, we can say for sure 2021, but we don't. I mean, like you said, we would love to be able to prognosticate this. But
well, so let's. This is a good time for us to segue to comparing this to the flu. Like, talk to us about mortality. We hear a lot of things like, a lot of people die from the flu, and we still had guests over, and how does this mortality? Two questions: has the mortality rate changed? Have we been able to make this a less deadly disease? That's number one. And number two, how does it compare to the sort of the seasonal flu and its mortality rate?
One quick comment about the flu. I would predict, so this is some good news. I think the flu rates in BC are going to be extremely low this year. Extremely low. It's less contagious than coronavirus. And I'll let Debbie talk a bit about mortality. But if you look at other countries like Australia, where they were doing similar stuff to us, the flu rates were extremely low. So that's a good thing.
Yeah, I mean, the measures to decrease the risk of transmission of coronavirus are the similar measures to decrease the risk of the flu plus the flu vaccine. And so if the majority of society is taking those measures, then we should see a decreased risk of transmission. The biggest one, other than the vaccine, one of the biggest ones is staying home when you're sick. But in terms of the mortality, I'm sure a lot of people have read in the literature or the news that the mortality has gone down, and it has gone down for coronavirus. And now the quoted mortality is 0.5%. That's the WHO mortality. WHO, and it actually has gone down, but no, there's no evidence that the virus is less virulent. It has the same virulence as before, but I think one of the things is that the denominator of testing has increased, so that's decreased the mortality. And also likely that people are recognizing symptoms earlier, so maybe presenting to hospital earlier. The dexamethasone is the only medication that's shown to decrease mortality. So if that's used, and then we've also in the healthcare system changed, we've learned. So we intubate people later. We put people on their stomach during ventilation, and a lot of those things have shown improved decreased mortality. So they're both we're testing more, so we're seeing the denominator be bigger, and also we've changed the way we've done things in the healthcare system. And very importantly, the healthcare system isn't as taxed as it was in the beginning. So we've been able to take care of patients throughout the world. And so if we can't flatten the curve again in this second wave and the hospitals get overwhelmed, then it's possible that the mortality will go up again. And that is a prediction in many healthcare systems. But no, we have not shown that with the mortality rate going down, that the virus has become less virulent. It's the same virus in terms of its virulence. In terms of the mortality for the flu, it's about 0.1%. So it's less mortality than corona, which is 0.5%.
So this is 5 times more deadly than the flu.
5 to 10 times,
yeah.
And the risk factors are pretty much the same, like we talked about, that they've identified in this good summary article: older age, COPD, chronic obstructive pulmonary disease, people with heart problems, type 2 diabetes, have obesity, sickle cell disease, chronic kidney disease, history of a transplant, and people that have active cancer. So those are the main risk factors that have identified, which doesn't increase your risk of getting COVID, but it increases your risk of having a rougher time with it. So that's important to distinguish, because I think some people thought that if they had a heart problem, they're more likely to get it. No, they're not more likely to get it. They're more likely to have a rough course of the disease pathway.
And that's the other thing about the mortality decreasing, is that the populations that are sick now with the coronavirus, or at least testing positive, are a different population in the beginning. They're younger patients who are getting it, younger patients in hospital. So we're seeing less mortality in that population than we did with the more immunocompromised patients that we saw earlier in March to June.
Let's talk a little bit about
did you want to segue into something else?
Yeah.
Okay. So right. So there's one more question on our prepared questions, and then I want to ask Camille's taken a lot of questions over email over the past couple of days, and as well there are many questions in the chat. Then I'm going to let Camille. I give her all the good jobs. She can decide which questions to ask after this. But the one thing I wanted to you to talk about is that there was a doctor in our community who mentioned that they've done some studies on athletes who've gotten the disease and had a lot of trouble returning to peak performance.
Yeah.
And perhaps just if you can help us understand, what do we know about the long-term effects of a disease on someone who's actually recovered?
So it's a very good question. There's this term that so we actually have one of our colleagues is actually doing a clinic for people that have had COVID, that have recovered, but that have persistent symptoms. And the term that they use is called long haulers, and it's a scientific term, but it's also in the lay press.
Or post-COVID syndrome.
Or post-COVID syndrome. But yes, that's correct. Some of the patients that they're seeing in the clinic are young athletes, professionals, have no risk factors, non-smokers, normal weight, young, and they're still having persistent myalgias, which means like muscle pain, shortness of breath, fatigue, and it can really affect that person's quality of life. And prior to that, they were in perfect health. And so that's a serious thing. And so there is a clinic now at St. Paul's to try to help those patients.
Can I speak to
Yes.
it? So I think it's a kind of a BC initiative. So lots of the health authorities through the province are having these clinics. So there should be one in all different health authorities. And this is being well studied throughout the world too, the post-COVID syndrome or long haulers. And really and it's not just people who were sick it could be people who were at home with very minimal symptoms, and plus people who were in hospital, and it's not correlated with how sick you were, this syndrome. Patients who are in ICU, they may have a separate thing, like a post-ICU recovery symptoms, and that's a totally different thing. But just in medicine in general, we see something called post-viral syndromes, that people after a virus may have. Some people recover quickly after having a bit of the flu, and other people can have months and months of fatigue, of muscle aches, of brain fog that just persists for a while. It's almost like the body was insulted by something, and it's led to the equivalent of a bit similar to the chronic fatigue syndrome, where you get brain fatigue, can't do what you normally do, really body's not as achy. So we're seeing that in coronavirus as well. The other thing that we see, other than the chronic fatigue type symptoms, that brain fog and fatigue, is shortness of breath. And that often does correlate with how injured the lung was. And there's many respirologists in the world and also in Vancouver who are following patients with lung function tests and CAT scans to see what kind of scarring and what kind of lung recovery there is. And then cardiac, the heart as well. So the heart, as Gil mentioned, can get inflamed with coronavirus. So the coronavirus has the infection itself, which is not just a lung infection, respiratory infection. It's a virus that can affect the whole body, the nervous system, the heart, but it's also it can lead to a decreased immune system, and it can also increase to an increased immune system, an inflammatory system. And that increased inflammatory system can also affect the heart. So we are seeing effects of heart or muscle weakness of the heart after the coronavirus too. So it's called a cardiomyopathy. And lastly, neurological effects, both that brain fog we talked about, but also numbness and nerve issues that people have, like tingling and nerves, and then blood clots from that pro-inflammatory cascade that happens. And the blood clots would be more in the acute phase, not in the post phase. So these symptoms of post-coronavirus and post-COVID syndrome or long haulers, the ones you hear in the news is mostly around the fatigue and the brain fog, but it really can affect the breathing, the heart, the nervous system, and really the quality of life of someone. And we're going to learn more about this. But as of now, we don't know the trajectory of how long it will be. It's too soon to know. And we also don't know who's at risk for those symptoms. Yeah.
So now I'm going to ask Camille to do the dangerous job of trying to figure out which questions to ask.
Hi, everyone. So we had a lot of questions. You did cover mask wearing, the importance of mask wearing, but a lot of people want to understand possibly why the province hasn't mandated when there is evidence to show that it helps stop some of the transmission. So, I mean, I'm sure you're not in the back room listening in on their conversations, but maybe there's is it a psychological thing? If you don't make people do it, they're more willing to do it because it's on their own free will. I don't know. What do you guys think?
I think that's a good point. I think it I think it's tough when you tell somebody to do something. People don't like to be told what to do, right? We're a free society, and so we like to be suggested what to do. I mean, when I go bike riding, I wear a vest, a reflective vest. I wear a helmet. I have a light that flashes in the front and the back.
True.
I wear gloves day and night. Doesn't matter, because I think each little element reduces the risk.
True.
So obviously I'm going to wear a mask, even if it helped me by 10%. So for me, it is I didn't have to hear expectations or mandates. But I think there's some people that say, you know what, I'm happy that they didn't tell me what to do and that it's an expectation. And I'm going to do it because it's told to me in a gentle way. And I don't think that's necessarily the wrong thing to do. And I think that the language that Bonnie Henry used was really good. And I thought that when she said, you know, when I go to the restaurant, or she said, when I go to a pharmacy, I wear a mask. And I thought that was really helpful, because it's showing that one of the leaders is saying kind of like, you know, leading by example. And I think that's a good pathway.
Yeah, I think part of it is like behavioral, like psychology of encouraging, suggesting versus mandating. And then the other thing is if you mandate it and make it the law, like there's usually the feeling of a repercussion around that. And I don't think there's, in our free society, we can have repercussions at this point, in terms of, at least the politicians probably don't think that there's a penalty that they could put on someone for not wearing a mask. So,
and maybe I can say one other thing is that there are people in the community that maybe don't have access to a mask, that can't afford one, and I think we need to be sensitive to that. And I just hope that you know, I like the way Whole Foods hands out masks, so you have to wear. They have a company policy that you have to wear a mask inside, but at least they provide it. And there's many retail places that do that, so I think that's excellent. And I think that we should just be sensitive that not everybody has access necessarily to everything. And I hope that the government would make masks available, just like they make other things available for everybody. Good question.
So and the other thing is that it's also early on. So if you just think about like how things catch on, bike helmets did catch on, ski helmets caught on. And so a lot of things preventative take time. And I think our public health campaign is just starting with that. So, you know, if this does last a long time, I do think that public health campaign will catch on. But I just historically, every public health campaign takes time, you know, in society. So,
I mean, it is interesting that on the buses where masks are mandated, unless it's changed, but I think that's the case still, there's been no transmission. But I also think that in buses, people are not usually talking to each other. They're sitting down, they're quiet, they're separate because there's only not a certain amount of people. So I think that's a good example of a essential service that's doing it as safe as possible. So the risk is not zero, but it's as safe as possible. And I think that, you know, some of the evidence, even in aircrafts, is showing that flying is probably safe with the way that they're doing it, because the Boeing planes, their air inside the cabin, get this, is changed every 3 minutes. The entire air volume is changed during flight. So that's really amazing. And so we know that the more ventilation there is, the less chance the particles can float and the less chance you're going to inhale them. And so I think that if air travel continues to be safe and makes you wash your hands, makes you wear a mask, and takes all those precautions, I think that air travel can be safe. And I think it's, you know, maybe more worrisome before and after in the airport or in other places where the ventilation isn't as good. So again, another optimistic thing, and the studies are showing that air travel can be safe.
That's great. A few people have asked in terms of effective masks. Have you heard anything about the masks that were developed in Israel, Synovia masks? They're coated with zinc oxide. They show no. Okay.
I haven't heard of it.
No.
heard of it on the chat?
Unless somebody on the chat knows about it.
No, someone in the chat asked, but
Okay.
asked about it. And then also in terms of air purifiers, HEPA plus air purifiers, are they effective at purifying virus from the air? Or an air conditioner, does that help move?
Yes, they're all good. The HEPA filter is just a high efficiency particles. I can't remember exactly what it stands for, but it captures the particles. And it's the number, it's MERV, MERV, which stands for something. And I think the higher the number, the smaller the particles it captures. So in the hospitals, it's finer particles. In the airplane, it's very, very fine. So yes, if you have a HEPA filter at home, that's great. It'll capture the virus as it circulates the air.
Josh. Sorry, Cole. We have someone over here making comments.
Josh may know more about filters than me, but
I was like, how do you know that anyway?
No, not a good comment. He knows very little, he said.
Can I actually, Camille, let me just make one other comment about medications, which is something that I totally skipped over. We talked about it in April, but I think this is really important. And I've got a lot of questions about this from patients that I see. So let's say you're on a medication like an ACE inhibitor or an ARB. So we know that the virus, when it goes into your body through those receptors that medication works on. So there was some people that thought, well, maybe we shouldn't take that medication because those viruses are going to be upregulated, which means that they may be more available for the virus to come into your body through in the lung. And so that, again, all the recommendations from the cardiac societies and the lung groups are saying that you should not change your medication regimen. And when you hear people saying that, just turn off the video or whatever you're watching, because people can get very sick by stopping medications. And so continue to take your medications unless you have specific advice that says to change it. Yes. You agree, Josh, right? Are we good for that one?
ACE inhibitors?
ACE inhibitors, ARBs, do not touch unless Josh tells you to stop it.
Continue your ACE inhibitor.
Yeah.
A few people have asked your thoughts. You're happy specifically at your kids' schools with kids not wearing masks, some wearing, some not. Do you think that like we're still on that trajectory? You know, is it good that kids, some are, some aren't? You know, because we say that teachers are encouraged to wear masks. I'm not sure that teachers are wearing masks in the classroom all day.
They should because they're projecting. So they would be. And the other thing that's interesting about kids is that there was a good study that is out of Germany that showed that if you're age 11 or younger, and you get the virus, you're much less likely to transmit it. So it's the older kids that have larger volumes when they breathe are more likely to transmit those virus particles like Debs was talking about. And so there's actually been not that many cases where kids get infected and then they pass it on to their parents. It's quite rare. And a lot of the kids have no symptoms, are asymptomatic, and they just get better after 2 weeks and it's done and they never knew they had it. But so younger children, less risk to transmit, older children more. So but I do think that if children can wear masks, they should.
So like, you know, I think what you're talking, Camille, the question that you're asking about kids and masks, I think everything that we can do to limit the transmission is great, but there will be scenarios where we're not fully preventing ourselves at that moment. So like, you know, do I let my kids go to a friend's house? You know, as long as it's within the restrictions that Bonnie Henry talks about. Do you go to a restaurant, et cetera, like all these different things. And I do think every scenario that you can avoid or prevent is a good scenario, but there will be times where you are not fully preventing, right? So you'll be at a friend's house or you'll be in a classroom where not everybody's wearing a mask, and you know, if you're someone who is on the road that you want to do the best you can to prevent, you're going to pick and choose what are the scenarios that are kind of like Gil said, that you are you going to be on the spectrum that you stay home alone the whole time, or are you going to be in the spectrum that you go to a party with 40 people? You'll pick and choose. If you're more on the spectrum of preventing, you'll pick and choose those scenarios, and you'll do your best to limit the scenarios. School, I think, is one, and as well as social interactions, I think, are scenarios that are very hard to fully restrict, and so we do our best in those scenarios. I think the younger the kids are, as Gil said, the risk is lower. It would be great if everyone could be wearing a mask, but it's very hard to have. I mean, you know, I have a 7-year-old. It's very hard for him to wear the mask the entire day. I encourage him to, but Charlie, do you wear your mask at school?
Yes.
The whole day? Yeah, I mean, I don't. He's here, but so I think it is challenging to wear masks the entire day. But and so that's where encouraging versus mandating, it's, you know, depending on ability, right?
But we are having friends over and they play outside without masks.
Outside without masks, yeah.
They touch each other. Yeah, I think that's okay. I think we need to have normal child development, and I'm willing to take that risk.
Yeah.
what are your thoughts? Someone asked a question about best facilities for treating the virus in British Columbia. Are all the hospitals working together so that, my husband always tells me we have a great healthcare system here and all of the hospitals are really run equally. So would you express the same and with this situation in terms of the ICUs and everyone sharing information and helping each other out? And
Yeah. Where actually there's a WeChat group among physicians. Most of them, and our one, most of them are from St. Paul's, but there's probably 250 or 300 people that are on it.
Providence, mostly.
Providence, and we get new information all the time, and people are selective of what they put on, but it's really high quality, and some of the articles have been really important. And you can't scour all the literature and find all the good stuff. And so yes, we rely on each other to pass on the information and to be aware of where the cases are and what the risk factors are. And I think with the long-term care homes, and that was really we learned a lot from those outbreaks, and I really hope that we can invest in those facilities to make them safer in the future, because those people are very high risk. They're older, they often have other medical problems, and I think Canada has one of the worst records in terms of the safety of long-term care facilities. So I think that's something we can work on as a province and as a country.
So to answer your question in terms of also about the facilities, I think BC had a lot of time to prepare. So most of the hospitals had action plans to prepare in terms of where the patient flow, which is, you say are all facilities equal? Well, part of it is, do the facilities have the ability to test for coronavirus? Do the facilities have the ability to protect the other patients, to protect from exposures, protect the healthcare workers, the housekeepers, the food service, the lab technicians, and then also the flow of the patients, and then do they have the ability to give them the intensive care support? And so I do think that most of the hospitals have plans, and good plans around that patient flow, protecting the healthcare providers, the people working in the hospital, as well as protecting the patients in the hospital. In terms of ability to, are all hospitals equal? Well, I think up until certain intensive care support. So sometimes some of the main hospitals, big hospitals, have ECMO, for instance. That's a specialized therapy that smaller ICUs wouldn't have. So, but apart from that, I do think like the hospitals are all prepared for the flow and for the protection of the other patients in the hospital.
Great. Okay, a few more questions. A few people have asked me about reinfection.
Yes,
I have that.
very good question.
That a bit.
Okay.
So I did speak. If anyone on this chat knows Victor Leung, he's a superstar at St. Paul's. He's where I get a lot of my my information from. He's a infectious disease doctor, infection control, med microbiologist. I asked him that question because I was scouring the literature around it. And basically to this day, there's only 6 case reports in the literature that are published. So there's probably other patients of people who've been reinfected. And so reinfection is real, it's there, and it's proven by, they actually looked at the virus and it's a different sequence than the first virus. So it's not that the person's virus persisted in them the whole time. They actually got reinfected with a second time. And so the thought about reinfection brings up a lot of questions about immunity, which I'll get to in a second. But in terms of the infection itself, we think that the second time you're exposed, you'd likely have less severe illness because you already have some memory cells that help protect you. Though out of the 6 case reports, 1 person actually did worse and actually died with their reinfection. So it's hard to know. So reinfection is definitely real. And there's maybe unreported cases in the literature around that. In terms of what does that mean for immunity? Well, we have a lot of unanswered questions with immunity. We still don't know, but the thought is that immunity, once you're exposed, is not lifelong, maybe 6 months. We don't know yet, right? It hasn't been around for that long, but definitely we don't think it's going to be lifelong, but maybe with repeated infections, the risk, you'll have some memory cells that help protect you. So just, now I'm told that we have the antibody test that we were doing for more research purposes and very specific clinical scenarios. But now you can actually go, I'm told, and pay privately through Life Labs to get the antibody test. But what to do with that information, we're not sure. It probably tells you that you've been exposed and infected, but we don't know how much, what that means in terms of reinfection. We also don't know what that means in terms of what your immune response is, right? It just means that you were exposed to the virus. We don't know much.
It doesn't
more
have
about that.
implications for the next
Yeah,
exposure.
it doesn't. We don't know. We can't. So if you get it, we can't. Your healthcare provider can't really guide you through discussing that and what it means, because we don't really know what it means. Maybe I'll know the next time we do a chat, but right now we don't.
There's a good question from Errol. He just asked, sorry, I just scanned the thing. Can recovered patients shed the virus? So that's really important. So it looks like we said, the day before you actually get symptoms is when you were the most infectious, the most contagious. And then after a 7 to 9 day period, it actually goes down. And so the 14 days, some authors are writing that may be a little bit on the cautious side. It's not a bad thing to be extra cautious, but it looks like after the 10-day mark, the chance of being contagious is way, way lower. Like the density of the virons in a exhaled breath is way lower. So if you're completely recovered, then no, you cannot transmit the virus.
So they actually now, like for re-swabbing, to go on what you just said, we had a case of 4 months later that the swab was positive in June, and then again positive in September, October. But that person in September, October was not infectious. It was just ongoing shedding and not infectious. But with all this new information, St. Paul's has changed their policy that if someone is COVID positive, they should be isolated if they're still in hospital. I'm not sure how long. It may be something up to 40 days. So not at home, not from a public health point of view, but they don't keep, at the beginning, we used to keep people isolated in hospital for the 10 days, as long as they were free of any symptoms. But now we extend it. Even once they are no longer infectious, we extend it just in case new information comes. We don't know what this shedding means yet.
And almost all the patients, again, just maybe this is a little too medicalized, but people that come into the hospital, we test them before they come upstairs, because we just want to make sure that the other patients that are there and the healthcare team is safe. So the emergency department is much higher risk, obviously, than, and we have one ward that we call a red zone where the patients are cohorted together. So let's try to limit exposure.
Do you think that taking multiple different vaccines give you better immunity?
No, I think there's going to be multiple different vaccines. I think there's going to be a lot of studies that come out, and I don't think there's going to be enough of each vaccine for everybody. So I think, I tend to like I think the Johnson & Johnson one is good. Well, I shouldn't make a public endorsement, but just reading it, I think that one is a very interesting one. The Moderna one's interesting, but it's a very novel way. You're injecting yourself with mRNA and you're telling your body to produce a peptide. So I know that sounds very medical, but it's a little bit interesting to think about, that you're directing your body to produce the antibody, whereas the more common one, like the old-fashioned one, was you would expose your body to a portion of the virus, and your body would say, "Ooh, that doesn't look familiar. Let me make antibodies against it." So to me, that's a little bit more. It sounds a little bit more, a little bit nicer, but that's not the right word. But it's a little bit more safer, maybe. But the Moderna one is definitely, you're injecting yourself with something that tells your cells what to produce. So it's very, very cutting edge.
Question from Josh. He's curious if you guys would get tested for antibodies.
Now?
Yeah.
I don't fit any of the scenarios that it would help.
But that's a good question, Josh.
It's
a good question. Like, some people say maybe healthcare workers should be tested more commonly, like they're doing in
for
South Korea.
antibodies.
But also or the nasal swab. Like,
nasal swab's a different question.
Yeah, antibodies. Yeah, what am I going to do with the information though? Let's say it's positive. This doesn't help me, because Debbie just talked about Victor's reports that you can get reinfected, and so it doesn't necessarily confer immunity. And I may be nervous that when I was in my infectious phase, that I infected somebody else. So no, I don't know. I don't know that I would get that.
You've been wearing a mask.
I wear a mask.
Like like a Viking, you
Yeah.
wear your
But I do
protector.
think I like the South Korean model. So what they do is that people can get tested very easily. There's testing widely available. There's these little telephone booths, and if you are infected, then you stay home, and the government helps you with salary support and food. And so there's this incentive to actually get tested and to stay home. Whereas I feel, and I could be wrong on this, and if Arnold and Herb are on, I think they are, they may know more about the business side of it, but I don't know if there's much incentive for people to find out that they're infected, because then they can't work. And maybe that would be a disadvantage to find out. So I think that there should be a link between the healthcare side and the business side, so that people are not nervous and don't feel ashamed about getting tested, and feel supported by the government, so that you limit your exposure. I think that would go a long way.
My last question is, are you finding evidence that the virus is more contagious with the mutation of it, like in the last, over the last few months? And you did say that they're finding that the mortality rate is lower, but is it more contagious?
So we think that the mortality rate is lower because there's more younger people that are getting infected
And testing more.
and testing more.
And maybe doing a bit better in the healthcare side.
Yeah.
Mm-hmm.
But it's not, we just know that it's actually, the reading I've done and also speaking with Victor, is that it's not more, the studies say it's not more virulent and it's not less virulent. So that probably means it's the same. It probably hasn't, all the changes in the virus, nothing's changed in terms of its virulence, is our thought. In terms of contagiousness, I don't know. I haven't read if it's become less or more contagious. I think we've now learned. So it was the same in March.
It's very contagious.
It was the same as it was in March, but in March we thought it was just droplet and not airborne, not aerosolized. Now we know it's aerosolized. So now we're saying it's more contagious than we knew it was in March, but it was the same contagiousness. Does that make sense?
Right. Yeah, totally.
Yeah.
Should we talk about masks for one more? Do we have one more minute just to review? Because I see people sometimes that aren't wearing it properly. So this is a standard surgical mask.
No, there's
and it has a visor attached, which I like. I wear it. This is the one I wear at work, and I wear a baseball cap, so it kind of feathers the top of this plastic thing, and it makes me like in a little shell. So I really like that.
But you shouldn't wear that one to show.
Oh yeah. Oh, okay. That's right. So it's harder to show. So, but when you put on a mask, what you want to do is you forget about the actual mask part. Just attach it to your ear. So wash your hands first, obviously, and then put it on your ears, and then tuck the chin part under. But then the thing that people forget to do is actually smooth the nose part. Every mask has a metal part, and you want to smooth it down to try to limit the air coming in and out. So, and really tuck it down. It takes 5 seconds, but I see people that really don't know what they're doing. The other thing is that the white side is always on the inside. If there's a blue and a white, the white is always against your skin. So the worst thing you could do is wear it backwards.
No, well, now if there's still skeptics around masks, there's really good. I mean, we could upload some of the videos, but wearing a mask prevents you from aerosolizing. You have less aerosolized particles, and if someone that you're with, if they're wearing a mask, they will have less aerosolized particles. So it's a two-way relationship. You're protecting yourself from other people's aerosolization, and you're protecting others from yours. So it's a really, really important thing. Even if you use all the other, the only time you shouldn't use it is if you're fully physically distanced and you're outside, outdoors. But other than that, like there's always a role for a mask if you're not physically distanced from people who aren't in your bubble and you're indoors, because it really does protect others as well as protecting you. The other thing to know is if it's not fitted properly, it doesn't work. So it's not so much the kind of mask. All masks, like a lot of cloth masks are good, surgical masks are good. I think they talk about masks having 3 layers is the best. So a 3-layered cloth mask is good, like 3 layers in it. But if it's too tight, the particles can come out from the sides. And obviously, if it's not covering your nose, it's useless. So a good fitted mask, whether it's a surgical one or a cloth one, and then protects others as well as protecting you. So it's a two-way street.
And so I guess that's the key takeaway message, is that there's multiple ways to reduce your risk: social distancing, hand washing, masks, vaccine. And that I think it takes a combination of all of those features to really minimize your risk of getting sick. I think that's a good.
You didn't list them all, but all the ones that
those are the main ones.
Staying home when you're sick.
Yeah.
And I think also government messaging is an important one too, which hopefully will continue, will help us decrease our risk.
Any other last questions, comments? I hope this was fun, everyone.
It was great. I don't there's a question from Mara Shanae. I don't know if you can see it in the chat.
Yeah. So about ME/CFS. Yeah, that one.
Yeah.
Yeah.
I didn't. I was.
So the question is there a connection between the post-COVID syndrome or long haulers with chronic fatigue syndrome? And yes, there's definitely a connection. As I mentioned, just like what Mara was saying in the chat, chronic fatigue syndrome or like syndrome is a common thing that happens it's not common, but we see it post viruses. I call it medically the post viral syndrome, where people get that brain fog and fatigue and maybe some shortness of breath and not functioning as well as they did before. And so we're definitely seeing the similar symptoms in post COVID. Yeah.
Thank you.
I hope someday we can talk about other scientific and medical health things, but I guess for the time being, we need to focus on COVID. So everybody stay safe, take care of each other and your families, and until the next time, I guess.
Thanks for having us.
And thanks for having us.
Thank you so much for coming back. I mean, I think it speaks to how popular this was that we had over 60 people on tonight. 60 computers, I should say. That's more than 60 people. And we're going to try. I think that maybe monthly is the right amount of time for us to do these. So really appreciate your input. I want to thank everyone for participating. I hope to see all of you either in virtual spaces or in safe synagogue spaces over in the near future. All right. Wish everybody a Shabbat Shalom.
Shabbat Shalom.
Good Shabbos.
Bye, everyone.
Bye-bye.